Moving on to our next talk, the management of rheumatoid arthritis has evolved remarkably, with disease-modifying anti-rheumatic drugs enabling sustained remission in many patients. However, the question of when and how to safely taper therapy remains a critical clinical challenge. Balancing the risks of disease flare against medication-related adverse effects and healthcare costs requires careful, evidence-based decision-making. Optimizing tapering strategies is therefore pivotal in achieving long-term disease control while minimizing patient burden. We are honored to welcome Professor Dr. Babur Salem, an eminent figure in rheumatology with distinguished academic and clinical career. Dr. Babur holds FCPS qualification in both medicine and rheumatology and a master's degree in pain management. He is also a fellow of American College of Rheumatology. Currently serving at Fauji Foundation Hospital, Rawalpindi, Professor Salem is widely respected for his contributions to rheumatology practice and education. We eagerly anticipate his expert perspective on this subject. Please welcome Professor Dr. Babur Salem.
Assalamu alaikum ji. I hope you can hear me loud. Thank you, Dr. Noor, for such a lovely introduction. You reminded me of my mother-in-law. She used to praise me like this. Thank you so much. Ladies and gentlemen, thank you so much for the invitation. I would like to thank Dr. Aflaq, Dr. Tafazil for inviting me. Indeed, it's a privilege, honor to be here and standing in front of you guys. And the topic I'm going to be, I've got no disclosures and this is the place where I work, it's Fauji Foundation Hospital, Rawalpindi. And the topic I'm going to be talking about is that how to taper or stop disease-modifying drugs in rheumatoid arthritis. And well, before I move on to my objectives, the point here is that we will not be talking about the patients who have an active disease. So I think that most of us know how to treat an active disease or a moderate disease or a low disease active. But I'll be talking about those fraction of patients who are in complete remission, who are completely fine, and they have a question, for how long do we have to take the medicines? So this presentation is basically, so keep this in mind, we are talking about only those patients who are in sustained remission. So these are going to be my 4 objectives. I'm going to talk about what is a sustained remission. We know that what is remission, but what is sustained remission, I'm going to talk about that. Tapering, how to be done, why it is important, and post-tapering relapse, is there any entity which is known as post-tapering relapse, yes or no? We're going to discuss about that. And at the end of the day, we're going to conclude my all these objectives. So, by definition, by the ACR and ULR, the remission is defined by at least for 6 months or more. So you need to know whatever the tool you're using CDAI score, DAS28, Boolean score, whatever the tool you're using, but the patient has to be for at least more than 6 months, and the steroids must be stopped at that particular time. So that's the most important point, because sometimes the patients say that patient is in sustained remission and the patient is taking steroids. So we won't be calling that a sustained remission. So by definition, sustained remission is any patient who is not taking steroids for at least 6 months, not requiring any painkillers, there is no evidence of synovitis, and he is in sustained remission for at least 6 months or more. So if we talk about the evolution of these criteria, they started back in 1995, starting from DAS28, RAPID3. Now we have a very recent one, which is known as the Boolean 2 criteria. If you see the Boolean 2 criteria is a less stringent criteria as compared to Boolean 1 criteria, because they have increased the patient's global assessment from 1 to 2 without compromising on the radiographic progression or on the health assessment questionnaire. The point here is that why they have done this. The reason is that they wanted to include more patients into the umbrella of sustained remission. So when they did this, they increased the figures from 14% to 20%. So without compromising on the health assessment questionnaire or on the radiographic progression. So now we need to know how much percentage of patients are in sustained remission. So, well, it partly depends upon which particular tool you are using. For example, if you are using a DAS28 to check for a sustained remission, which is not a very good tool to assess sustained remission, around 30% of the patients are going to be in sustained remission after a period of 6 months. But if you're using a Boolean criteria, which is around 20% of the patient would be in sustained remission. So the cutoff story is around 20 to 30% of the patients are in sustained remission. So this presentation is going to be about that number, that 20 to 30% of the patients who are in complete remission. We are going to be talking about those groups. We are not talking about the rest of the patients who have an active disease. We all know that we have to treat an active disease. So this presentation is basically targeting that cohort, that small number, around 20 to 30, who are in sustained remission, who keep on asking you that, Dr. Saab, I come to you, you don't do anything, you check my test and you take a fees. You don't do anything. So nor you're reducing my dose, nor you're increasing my dose. So this presentation is basically for those patients. So the next question is DMARD-free remission possible? How many of you think that if we stop the medicine, the disease is not going to come back? Okay, how many of you think that disease is going to come back? Yes, you're right. Well, we'll discuss about it. You need to know the definition of DMARD-free remission. So what happens is, first of all, the patient comes to us on the green part, you treat rheumatoid arthritis. And with the passage of time, you target and the patient becomes into remission, for example. And then you plan, let's stop it. You don't do it in general, but for example, if you stop the DMARDs, and after stopping the DMARDs, patients remain in remission for at least 1 year. So patients without on DMARDs for at least 1 year and still remaining in remission, that is known as DMARD-free remission. I want you to know this definition because we are going to be talking about this definition in the next couple of slides. So DMARD-free remission is no DMARDs in an RA patient and the patient is perfectly fine. So is it possible or not? Well, let's see. Well, this is the data from the two very, very important cohorts. One is the Leiden Early Arthritis Clinic, and the other one is the T-REACH cohort. And when we talk about rheumatoid arthritis, we always give a lot of respect to these cohorts because they have got a very stringent criteria to include in their patients. So those patients, they say that any patient who requires biologics ever in their life, ever in their life, DMARD-free remission is not possible. They could not find a single patient who ever required a biologic in their life, and when they stopped the medicine, it had a relapse. So that is the point number one. However, the patients who do not require biologics or targeted synthetic DMARDs, probably the DMARD-free remission may be possible. And how much it is possible, we're going to discuss about that. Well, this is the retro trial based on sustained remission by the end of 12 months. What they did was they divided into 3 groups. In one group, they continued the DMARD, and by the end of 1 year, they saw that around 80% of the patients remained in remission. And in the second group, they start doing the tapering, and half of the patients still remained in remission. And if you see the third part, that one, they stopped the DMARD, and after 1 year, around 40% of the patients remained in DMARD-free remission. They had nothing. So these figures are very astonishing because we used to think that, like all of you raised your hands, that we know that the disease is going to come back. So this is a new data, and they say that probably if you select the patient very rightly, the new figures are quite high, as shown by EULAR and ACR. They are very stringent. They say that every patient is going to come back. But the new data is coming up. This is evolving. They have not added this in the recommendations, but this is a new data that probably the figures need to be studied more. Okay, so question to this is that, is DMARD-free remission possible? Probably, yes, it is possible. So what were the predictors of sustained remission? Who were these patients in which the disease didn't come back? Well, This is the data over a period of 17 years. They tried to see the data, the predictors. They collected data of 18 predictors. They included RF factor, anti-CCP antibodies, acute phase reactants, smokers, comorbidities, so many things. But what they found, these were the 5 main predictors, which they found that in these were the patients in which the disease did not come back even after 1 year. They were younger patients, they had a shorter duration of disease. They, at the time of the diagnosis, they had a good quality of life. They were non-smokers and they did not have any erosions on the X-rays or ultrasound. So, the next objective is, why do we want tapering? Why not just continue on the treatment, go on and on and on? Tapering, why it is important, how to be done, which drug to taper first? Well, nobody wants to take the medicines for the rest of their life, even us, and long-term side effects, cost issues, patient preferences, compliance issues, so many things. So this is going to be you can see the below, that is the tapering, why it is important. Well, let's see the data from the EULAR 2023. EULAR straight away says dose reduction can be considered, but discontinuation is not advisable. And if you see the data from the ACR, there is a double take for continuation. They prefer that don't go for tapering, just go on and on and on. However, if somebody wants to reduce the dose, you may reduce the dose, but discontinuation is still not recommended. And despite of that retro trial, the guidelines say do not stop the medication. And the rationale behind this is that we have seen that retro trial has shown that around 40% of the patients, they will remain DMARD free. But still, the data rationale by the ACR and EULAR is that the relapse is still very high after 1 year, which is around 56 to 87%. So that's the rationale, they avoid discontinuation. So next is, if we plan to taper the medications, which we should, so what should be done? So this is the cartoon which I have made, is that if your patient is taking a monotherapy, first of all, identification of the patient is the most important thing. Identify the patients who are in sustained remission. If you are selecting the patients who have a low disease activity, patient is definitely going to relapse early. Apply stringent criteria, apply like Boolean 2 criteria rather than -28. Then it has to be a shared decision. Take a consent from the patient that we are going to be doing this, but if there is a relapse, please inform us at the earliest. So the third point is gradual dose reduction is recommended and avoid discontinuation. So these are the 4 parameters. And if your patient is taking a combination therapy, for example, with methotrexate, the patient is taking sulfasalazine or maybe triple therapy. So first, again, the first 2 steps are the same. Identify the patients, have a shared decision, and followed by, if the patient is taking dual therapy, just reduce the dose to monotherapy. If the patient is taking a triple therapy, reduce the therapy to dual therapy, and then gradually monotherapy. And if your patient is taking injectables, there are 2 ways. Either you can go for dose reduction or dose spacing. Both these methods are recommended. Let's see what EULAR has to say about this. Well, EULAR has no problem. You can do whatever you want to do. Dose reduction or interval spacing, both are right. Just do it. Now the point is, which agent to taper first? Should we taper? How many of you would, for example, if your patient is on methotrexate along with JAK inhibitor, so how many of you would stop or taper methotrexate first? Please raise your hands. Okay. And how many of you would prefer to taper the JAK inhibitors or the biologics first? Okay. Now let's see what does the data says. Well, if you see the ACR, as per the 2021 guidelines, they say that they favor conventional synthetic DMARDs over biologics or targeted synthetic DMARDs. We'll discuss about the rationale behind that. And if you talk about EULAR, they have no preferred tapering sequence. So both the societies have a little bit difference in between, but let's see the data. Well, these are the landmark trials. I would like you to remember these 3. These are very, very important trials because they are working so much that we have to reduce the medicine. Everybody wants to get rid of the biologics or conventional synthetic DMARDs. Either it's a tapering, either it's a discontinuation. So I'll start with the very first and the old conventional trial, that is the TARA trial. This was published back in 2020 and in the Annals of Rheumatic Diseases. And what they did was, in half of the patient, they tapered conventional synthetic DMARDs first. like a few of your people wanted to do the same. And half of the people, what they did was they tapered the biologics first. And what they found was, they found that the order of tapering did not affect the flares. So as this is just like the data which was being published by the EULAR as well. That was again taken from this TARA trial. So you can do whatever you want to do, but this was an old study. This was followed by a SEAM trial published in 2023. And well, what they did was, this is a little bit different from the TARA trial. What they did was, they divided into 3 groups. In the first group, they continued the treatment. And they found that around more than half of the patients were in remission. And the second group, they stopped methotrexate. You can see that only 49% of the patients were in remission. But in the third group, when they stopped biologics first, very few patients were in remission. So conclusion from this data was that disease relapse was more in those who stopped biologics first compared to those who stopped conventional synthetic DMARDs. So this goes in favor of ACR rather than EULAR. And if you see the more recent data, again published in 2023, published in Rheumatology journal, I would like you to focus on the middle 2 circles, and one in which the conventional synthetic DMARDs were tapered. They found that the relapse was only 9%. And in those patients in which the biologics or the targeted synthetic DMARDs were tapered, the relapse was 44%. Again, the conclusion is patients who tapered biologics or targeted synthetic DMARDs prior to conventional synthetic DMARDs were more likely to experience a flare after 2 years. So again, this study goes in favor of ACR 2021. So no one is right, no one is wrong, but keep your eyes open. Which one do you want to do it? So the next point is there any entity risk of relapse post-tapering? Yes, we have a relapse. Again, this is the data which shows that if you taper biologics first, there is a very, very high risk of relapse. In case of TNF, around 75%. In case of tocilizumab, it is around 84%, even more higher. So the rationale is that if your patient is in sustained remission, the maximum relapse is if you taper biologics first, followed by JAK inhibitors, followed by conventional synthetic DMARDs. So it is wise to taper conventional synthetic DMARDs first rather than tapering the JAK or biologics. So this is going to be my last slide, and my first conclusion is that, is tapering possible? The answer is yes, definitely, but choose the patients wisely and have a shared decision before you try this kind of thing. And identification of the patient is the most important key thing. You need to remember that. And avoid discontinuation. It is wise to go tapering, gradually slow in decreasing the doses, then number of medications, rather than abrupt discontinuation. And the last, I feel that this is my anecdotal experience as well, based on these trials, that taper conventional synthetic DMARDs first, followed by JAK inhibitors, and followed by the biologics. Thank you very much.